All right. Okay, they're all set.
Okay. Sorry about that. Let's go ahead and call the meeting to order. Thank you, everybody, for being here. Shelley, let's start with the roll call.
All right. Allison Welch.
Present.
Ariel Tarango.
Present.
Barb Stolfus. Present. Candace Williams.
It's right there.
Is she on? Okay. Carrie Lewis.
Present.
Dale Woolridge. Deb Burkick.
Present.
Garth Gamer. Heather Miller.
Present.
James Cecilini. Josh Gaither. Julie Augenstein. Laura Smith.
Present.
Maria Salas. She waved to me. She's in the room. Michelle Guadnola.
Present.
Paul Dabrowski. Ralph Kelly.
Present.
Ray Perla.
Present.
Rebecca Harrell. Sean Bowker.
Present.
Tiffany Stewart. Yes, she's in the room too. Tom Flanagan. We have 15, we have 4.
Candace Williams is here.
Oh, thank you, Candace.
Okay.
Excellent. Thanks, everybody, for attending. We'll start with the chairman's report. First thing on the agenda is the attendance report. Please do take a moment to look at the attendance report. We do appreciate you all taking the time to be here. Just as a reminder, if you do miss 2 consecutive meetings, the Bureau staff will reach out to you and ask if you wish to continue to serve on the committee. As you can tell, having a quorum is important to ensure that we can continue to do meetings. Next, let's turn our attention to new members. We have several new members today. Barbara, you want to do a brief introduction? Thank you for being here.
Good morning. Yes, I'm Barbara Stolfus. I work here in the Valley in aeromedical and have been a flight nurse for 15 years and hope to add some value to this.
Thank you for being here. Maria?
I'm Maria Salas. I work for Honor Health Deer Valley. I've been there for the last 22 years, the last 7 for trauma. I'm the trauma registrar lead, and nice to be here.
Thanks for being here. Appreciate it. And last, Ariel is, online. Ariel, you want to introduce yourself?
Yeah, hi, I'm Ariel Tarango, and I work for the Arizona Department of Health Services in the Office of Injury and Violence Prevention, and I am the naloxone program manager for the state. I am taking over for my former supervisor, Jackie Kirk.
Excellent. Thank you for joining us today. Finally, let's briefly look at the vacancies. There are currently several vacancies. The first is for ground ambulance or first responder premier EMS agency QI officers in SAMES or AIMS. To apply, please contact Sarah Parati at the SAMES region or Peggy at the AIMS region. Then there's also a position for the state designated level 4 trauma center program manager. If you're interested in that, please let Shelley know. And we'll hope to get those. Oh, I'm sorry, there's one more I missed. There's also a pre-hospital EMS coordinator in SAMES. Again, contact Sarah Parati for that one. That ends the chairman's report. I'll next turn it over to Chief Garcia for the Bureau updates.
All right. Well, good morning, everyone. I hope you can hear us on these microphones. It's really nice to have folks in the building and on the line today for our TEPI meeting this morning. I'll start by introducing some of our new Bureau staff. Today on the virtual link, we are joined by Lehia Castro. She is a new project coordinator senior for the Bureau of EMS and Trauma Systems. She is joining us from Pima County, and she will be helping us to implement a new image trend licensing management system over the next year. We're very thrilled to have Lehia on board, and we look forward to sharing updates with this group and all the stakeholders in the coming months regarding a new licensing management system from Image Trend that will be used for EMCT certification in the new year. So more to come on that. We also have in our presence today, I know that, Marissa, I know you're not new to the Bureau, but if anybody has not met Marissa Salgado in person, she has joined us in the last year as our base hospital program manager, and she is a great resource and liaison to the community. And if you've not met Marissa, we encourage you to get to know her as well as one of our newer team members. There are a few promotions within the Bureau recently as well. Taylor Pike, I believe, is probably logged into the phone. She is our new section chief of ambulance services within the Bureau. And Noreen Adlin, I believe, is also joining virtual today. She is our new section chief of trauma and pre-hospital coordination. And so we look forward to getting to know you all as the Bureau gets fully staffed. I would be remiss if I didn't also recognize Shelley Bissell today, our program specialist, who really keeps the Bureau on track in terms of all of the public meetings. And Shelley, we appreciate everything that you do as a Bureau and all the stakeholders. So I'll jump into some department updates next. We have quite a few legislative and rule updates that I'll try to highlight very briefly, and we will come back for EMS Council in September to provide a more in-depth overview. I think we have a packed agenda today with 4 public meetings. Following this meeting, we'll have the Education Committee convene, and we will be joined by National Registry for some important updates to keep everyone in the loop on what's happening at the national level. You all know we also have PMD this afternoon that will go through the T3Gs with the goal of refreshing all of our guidelines by 2023. So some big stuff happening. Most recently, we have also convened an EMS and hospital collaborative here in the Central Region to start to talk about patient triage and consistent ambulance offload plans, as well as the use of diversion within the Central Region. These are such important conversations as we look ahead in the coming months, and we want to continue to invite stakeholders from both the EMS and hospital side to participate in these important conversations. On the legislative and rules update side, I'm sorry to take up a little bit of time, but for awareness, we have a few bills that are general effective date this year. They will go into effect September 24th of this year. House Bill 2431 on emergency medical services transport, House Bill 2407 on ambulance mileage rate calculations, and Senate Bill 1210 on transportation for court-ordered treatment. Those 3 bills, again, are general effective date, and they will go into effect on September 24th. There is another bill, House Bill 2609, on ambulance services and certificates of necessity. That one, however, is a delayed effective date and will not go into effect until January 1st, 2024. So certainly we have some time on that bill and getting ready to be able to implement what is outlined in that legislation. The department will continue to participate in quite a bit of rulemaking this year, especially in response to all of the new EMS legislation. And again, we'll look forward to coming back for EMS Council to give more in-depth updates. If this group or any of the others today have specific questions on legislative or rule updates, please let us know. And we look forward to a packed agenda today.
Excellent, thank you. Next up, naloxone leave-behind program and ADHS opiate website. Dr. Brett.
Good morning, everyone. Thank you for joining us today. So the naloxone leave-behind program, I know I keep mentioning that at each meeting, but I think if anyone's seen some of the recent media and reports that have come out from the CDC, we have been seeing a continued increase in opioid overdoses and deaths. We really want to help publicize this program as much as possible. We do have the link on the agenda if you want to go to our website that has all the resources if your agency would like to implement an naloxone leave-behind program, including a standing order if you're a BLS-only agency, Otherwise, there's some sample educational pamphlets that can be tailored to your community, the training PowerPoint that was put together by the Education Committee, and then a number of other naloxone and opioid-specific resources from the department as well. There is quite a bit of opioid data that's on our website. Some of this is EMS and law enforcement specific, others are more just generalized from the hospital data as well. So if you are looking for any opioid and naloxone related data, that is on this website too. So we will just continue to share that messaging. I know we have Ariel on the phone, who's been a wonderful partner with her bureau in providing many EMS agencies with naloxone. So just a big shout out to that group. I think that has been a huge benefit to Arizona over the last couple of years. They have really been the source of providing many rural EMS agencies with naloxone for their communities. So just wanted to quickly touch on that. And I think Anne is on vacation this week, but I don't know, Basil, are you able to give a quick update regarding the 3.5?
You want me to jump in?
No, I don't have any update from Anne regarding that.
So the quick update is we just want to make sure we put on all the providers' radar that BEMSTS 3.5 is coming. So for all EMS agencies that report through patient care records and have an ePCR system that links up to AZ peers, we are transitioning to the NEMSIS version 3.5 reporting structure by July of 2023. So we have 1 year. We wanted to give everyone a 12-month heads up that we have until July 2023. And if there are any questions, you all know Anne. I think she's at a conference this week actually talking about NEMSIS 3.5. But if you have any questions, she's asked that you please reach out to her. Her email is ann.bosbrink@azdhs.gov.
Excellent, thank you. And last thing on the agenda, the Arizona State Trauma Registry updates. Carissa.
Good morning, everyone. So just a quick update. So some of you may already know, our trauma registry vendor ESO is going to be phasing out Trauma One within the next 3 to 5 years, and they're going to be setting up and offering a new different registry system as a replacement. We don't have an exact date for when this is going to be happening. They've kind of just given us that 3 to 5 year time frame, but we're preparing now. We don't want to wait until the last minute. So right now we're kind of just looking at all of our options to see what vendors are available and what systems there are out there. We definitely want to keep all of the stakeholders in the loop and get everyone's feedback as we go through this process. We just wanted to make sure that everyone was aware that this change will be happening in the near future. So we're going to have some meetings going forward just to make sure everyone's involved and we address concerns and look at what this process will look like. So if anyone has any questions that they want to ask before we have those meetings, you can email me. My email is carissa.wilson@azdhs.com. So thank you.
Thank you very much, Carissa. Moving on to updates from our work groups. First up, Trauma Registry User Work Group. Britt?
The main two things is we're just waiting for ESO to finalize the contract to change to AIS 15. And then we were having trouble linking the PCR in Trauma 1, and that has been resolved. Those were the only main two things.
Thank you for the update. Trauma Program Manager Workshops. Heather.
Hi, good morning. Nothing new with the Trauma Registry Program Manager Workshops. They're working on getting another meeting scheduled, and they're trying to work on making it live or in person and via Zoom so that we can get back on track. They did update the listserv, the Center of Rural Health that we use for the trauma program managers to communicate on. There was a new link, and that got updated and sent out to everybody, but nothing new other than that.
Excellent, thank you, Heather. Last, EMS Registry User Groups. Ray.
Yep, nothing, just to real quickly reiterate, last weekend reported that, the August go live next year for 3.5. The other thing, she had emailed out the preliminary 3.5 Spinatron, so you can look at the data sets that are going to be coming in. It adds a few new ones to so everyone can have a look at them previous. And then the actual next meeting for the EMS Rug group is August 15th at 10 a.m. and there'll be invites before then sent out to everybody.
Excellent. Thanks very much for the update. All right, moving on to discussion and action items. I believe we have all discussion items today. The first item is to discuss fall data for ground level falls with. Oh, my bad. 100% my fault. Sorry. Let's take a moment to review the minutes. Please look at your packets or your electronic records. Take a minute to look at the minutes, and I'll look for a motion to pass those or amend as needed.
This is Ray Pro. I make a motion to approve the minutes.
Thank you, Ray. I have a motion. Second. Thank you.
This is Debbie for Cake. I second it.
All right. 2 seconds. We'll take 2. All in favor, please say aye.
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 Thank you. Any opposed? Same sign. Thank you. Minutes are approved without any changes. Now we'll move on to the discussion of ground level. I'm just so excited about ground level falls with hip fractures. Couldn't wait. All right, moving on. Ground level falls for hip fractures.
So I think the question was that can we do some kind of descriptive analysis on ground level hip fractures using the database available to us? And we do have hospital discharge database, trauma registry, and EMS registry. All 3 registries, the timelines are a little different. Hospital discharge database are a little 6 or 8 months behind. So there are a few differences between the registries, but all 3 registries have ICD-10 code information available. So, once we define how we want to define a ground level hip based on the ICD-10 codes, we can definitely do the analysis. I just need to know what this committee is looking for.
And Sean, I believe you were the one who brought this up at the last meeting, but asked also if she could address that. I'm not sure if you're able to clarify kind of exactly the data you were looking for with that.
I think at this point, we have the big mismatch with regard to the trauma registry for the state versus the National Trauma Data Bank. Currently, just for those who don't know, in order to meet trauma inclusion criteria for the state's trauma registry, you have to have been transferred from another facility in order to be included if you have a ground level fall hip fracture. Whereas the National Trauma Data Bank captures all of those patients, but it's only captured from centers that report to the National Trauma Data Bank. So I think it would just be helpful for us to know the volume of those patients. How many are we actually seeing? How many are dying from those injuries? And then another helpful thing would be complications, age of the patients, etc. Because if we're going to do any kind of injury prevention for our #1 cause of injury, we need to know more specifics. And Vatzel, I can send you an email with some things that I would really love to see in a report.
Yeah, definitely. So let's do one thing. I think this looks like more like an ad hoc report. Rather than including this information in the annual report, we can do a separate analysis on that. And if you want to send me some details in the email, then we can go back and forth and, kind of figure it out what we want to get out of this.
Fantastic.
That sounds
this
good.
is Candace Williams, Rehab is my specialty. My question is, how can you follow the patients when they go in and where they're, in terms of their discharge, are they, discharged home, a SNF? those are probably the number 2 dispositions when you're dealing with a hip fracture and ground level fall.
So just to clarify, the question is looking for the disposition where they're discharged to home versus NIP, is that correct?
Correct. And then the other thing is when you look at complications, can you look at traumatic brain injury? Like subdural hematomas, things of that sort.
Okay. Yes. So it would be like, one of the diagnostic codes for the patient, and then we can look for among the patients with a ground level fractures, how many had traumatic brain injury too. So that we should be able to do that.
Thank you.
Any other things that people would like to see in that? It sounds like Sean will email Vossel, but just if anyone else has input they would like, you can either email Vossel or share that here today.
Yeah, definitely, and we can develop an ad hoc report on ground level hip fractures. Yeah.
Okay, I don't think we need a motion or anything, purely discussion. All right, moving on then. Anything else on the fall of ground level hip fractures before we move to the next one? Okay. Next item, discuss trauma snapshot.
So I think I can just kind of tee up the question for Vossel. There was a question at the last meeting, 2 that came up regarding the trauma snapshot. The first one was if we could include the top 6 mechanisms of injuries for pediatric patients, and then defining this group as 0 to 17. I wanted to make sure that that was what this group wanted before Vossel made that update for the upcoming year. So that was the question from the last meeting. So just wanted to clarify that was in fact the request was to do top 6 mechanisms of injury specific to pediatrics, with the definition of pediatrics being 0 to 17.
And so current snapshot is 0 to 17, and if this is what we want to continue, then we'll continue doing that.
Any comments, thoughts, suggestions on the 2 items for the trauma snapshot?
This is Kara from Phoenix Children's. I think this would be excellent if we can get this. So I appreciate you guys looking into this.
Okay.
Awesome, you're going to be busy.
And then D was just a clarification. So.
All right. So I need to do D or no?
And I think that was just for the follow-up piece. There were some questions about the annual report versus trauma snapshot. What was the age for pediatrics? So Vossel confirmed that is 0 to 17 for both.
Okay, thank you. Next up, discuss patient transport trends over time.
I can give a little background.
Yeah,
Vossel can kind of explain what she can do. So there was a question regarding are we able to look at transport trends over time? So knowing that with COVID, we've seen huge fluctuations in our transport volumes and seeing some of those trends, certainly 2019, 2020 were very different years. 2021 started to normalize a little bit, but we've still seen some variation. And so the question from the last meeting was regarding transport trends. So we just wanted to make sure that that was the question, and then Vossel can kind of speak in terms of if that's something that we can do on a regular basis moving forward.
Yeah, so I still need a little more information, like what we are looking in terms of transport trends. Definitely we do collect a lot of information on transport times, who are transported, and things like that. But I needed a specific information that what year we are looking for.
I don't recall who had asked the question at the last TEPI meeting, but I wanted to make sure we brought that back to this group just to clarify, so that we've also had enough details to be able to run that report.
That's what minutes are for me. I frankly have no recollection of that discussion whatsoever.
I think some of the details that Vossel would need to know would be, are we looking for just a specific number? Are we looking at a percent of all calls? So dispatches, what percent are transported? Are we looking at 911 in a facility or both? So some of those kind of more detailed pieces of information.
Right. I mean, are we just looking at the number of people transported, because we know that, the volume did go down during the COVID time, less people were going to the hospitals. Is that what we are looking for, over the years, just the numbers, or there is something else? We want to see the age and gender and demographic things during that period. I just need some more information.
When I think about the things that the agencies tend to think impacts their day-to-day, the number of transports, things like transport offload times, the numbers of interfacility transports going to and from, like freestanding emergency departments and things like that. Those are, things that come to mind in terms of sort of transport-related numbers that have an operational impact. I don't know if that was the intent of the agenda item, but the numbers of ALS versus BLS, that's a pretty simple one to get, but it does give you a snapshot, I guess. So.
Would you mind working with me through the email to develop a report? Is that how we want to proceed, or? Because I will need further, because the question will come up as I start doing analysis, and then if somebody wants to.
Yeah, I can certainly help out.
So if I can just ask a question, I'm not sure what the goal of this is.
Yeah. Right, so that's why, even I don't know, so that's why I need more information.
I don't remember this conversation, I don't remember the request. Is the goal to understand how many times we transport people? I thought that's already there. We have the number of transports.
That's easy enough. Just like we can get that, but I also need to understand what is the goal, then I can gather more information on that.
I think more specific things that may be more operationally relevant, as Amber was saying, that's what might be more useful to run a report. So also trying to do the workload to kind of create a report, we want it to be something that people can actually utilize, not just have a road number that just shows, yep, we transported 50,000 people. So I think something that's more operationally useful. I know something that has come up quite a bit is transports between freestanding emergency departments, then to another hospital. That would be something that's new for us, but we'd have to then look at kind of essentially the location and name of the sending facility as our filter point of an outgoing transport. But certainly if that was something specific, we could look at that. I think we're trying to see something that is operationally important as we start seeing more of those types of facilities opening.
Yeah, that question comes up a lot. And that's a hard number for us to get as an EMS agency, because so many different agencies may transport to and from the same freestanding emergency department. So when we've tried to look at what the operational impact is, we can kind of get a number, but we don't really know necessarily when we take a ground ambulance to the freestanding if they're going to subsequently be transferred. So for regional systems, it might be helpful.
Dr. Gamer, I see your hand up.
What scenario what you described right now, there is those will be two separate records in AZPOs as it is. So there is no way if you are telling me that that's patient A when transferred by the agency to a freestanding emergency, right, and then from there again to another agency, there will be two separate records in our registry as it is.
Dr. Gamer?
Yeah, just to I agree with everything said about how this could be a mechanism to meaningfully figure out how many secondary transports occur from various facilities. I don't think it would need to be confined to freestanding EDs or the hospital satellite EDs, as some of them are termed themselves. But what kind of veering off on that, is this a mechanism to track refusals of transports, and B, would this be a way to prove the effectiveness or lack thereof of House Bill 2431?
Interesting question. In the database, we can look at things like refusals, right? That's one. In the database, we are able to look at patient refusals.
Patient results?
Patient refusals.
Oh, patient refusals, yes, definitely, yeah.
So that could be something that we look at. In terms of a report, when we think about things like transport trends and especially increasing transport trends as of late, are we thinking along the lines of this is information we want to incorporate into a snapshot like we did in the last year? So last year we had the trauma snapshot and we also did an EMS snapshot that really gave an overview of some of the transport trends.
Right.
Are these things that would be most helpful to incorporate into that type of an infographic snapshot?
So my personal opinion, I think any data that we generate should have an actionable or purpose-driven reason for reporting. I think on this one, I'm really struggling to see the purpose of the data. I mean, yeah, it's interesting if our transports are going up, but we all know that at a local level. It's interesting if our inter-facility transports are going up, but we all know that already. I think my question for this group would be, what do we do with that data once we see it? Does that change anything? For me, I'll be honest, it doesn't change anything we do. If it helps for some funding thing, then maybe that's the reason to do it. If you look at it in comparison to the ground level fall item, ground level falls, it's a big deal. We can do some education, some interventions, perhaps targeting that. I don't see the intervention that results from this data.
So we put a hold on that right now, yeah, till we figure it out.
I think Bossel and her team do a lot of work. So between the trauma annual report, the EMS annual report, and the big change to the trauma annual report based on feedback from this group is that we are expanding that report. It's going to have a whole new section that is going to compare level 1 facilities versus level 3 and 4. So that is a huge addition to the existing trauma annual report. So those are definitely going to be some big workloads. So if there's not something that we can necessarily do with that data, I would prefer not to add to Bossel's workload if it's not something that's actionable per se. But I think certainly ground level falls, we know that that is a huge impact on the healthcare system. And certainly looking at complication rates and dispositions. And again, pediatric mechanisms of injuries, these are things that we can do some injury prevention work with, which are really important. So her team does a lot of work. So if we don't feel like this is going to be something actionable, I think it's reasonable to potentially hold on that.
And just to add on, timing-wise, in terms of looking at the trauma data, we do have the trauma annual report. That is the STAB report that will be available this fall, because we do produce that every fall. But in terms of following up on some of the EMS patient transport trends, I think our timeline to look at that will be after this fall, right? That'll be closer to the end of the calendar year that we'll begin looking at that information and developing reports. So that timing-wise, that is very helpful to us with our small and mighty team.
All right, then the next discussion point is trauma scene time definitions. We'll need some background on this one to lead the discussion.
This was also a request from the last meeting. I believe, Dr. Gamer, you had mentioned wanting to know some information about trauma scene times. That was my note from that meeting. I don't know if you wanted to expand on that.
Well, I just think that if we have access to that data, it might be useful for individual medical directors to discuss the on-scene dynamics and what might aid that particular agency in minimizing scene times. But first, you have to I guess get average numbers across the system, and then cone down on individual agencies in private reports. That's kind of where I'm going with that.
This is Kara from Phoenix Children's. The only thing I would say that might be difficult with that report is that the trauma centers who feed a lot of that information into the state's registry, it's dependent on whether or not we have those run sheets to enter in the data. So it might not be as complete as we would want it to be.
Right. So over the time, what my experience is that over 30% of the data is usually missing we do not have the injury time for me to calculate the trauma time. So it's around 30%.
I think there would be a significant amount of work in trying to divide the data up by size and type of agency as well, because we have such a difference in rural versus urban, and those are all going to have very different scene times for very different reasons.
True.
So I think that there has to be a lot of thought that went into how to even analyze that data because of just the variability across the state. So I think one thing that would make it very difficult to do.
I was just wanted to ask the question. It sounds like there's a hurdle for examining it on such a broad scope. This is probably best left to individual agencies.
Yeah, and I would also add one other potential confounder. I think what we've learned through the EPIC work and TBI is that, and through many other works, the concept of the golden hour is very antiquated. We all know that. And for some traumatic injuries, pre-hospital on-scene care is much more important than for others. So in order to tease out, was this an isolated head injury where it's much more important to get oxygen and IV fluid on board on the scene before transport than a short scene time compared to penetrating trauma where that short scene time is much more important. Trying to tease out those nuances, I think, could really make this one a very hard thing to digest. It kind of pushes back towards the load and go day of pre-hospital trauma care, which at least for my agency, we've tried to move to a more advanced understanding of trauma care than that.
Sounds like that is something we will put on hold for now. So good discussion. Wanted to make sure with bringing Bob Phil's expertise to here that we don't assign her any workload that's maybe not the best example of what the group's actually asking for. So thank you for going through all of those again.
All right. Any other discussion before we move off of our discussion items? I want to make sure everybody had a chance. A lot of quiet room space. See no hands raised. I'm trying to keep an eye on the hands. All right, moving on then. Any agenda items to be considered for the next meeting?
I don't have an agenda item, but I have a request to Shelley. If you know you're going to make the effort to travel in, just give me a heads up and I'll get a nice folder and table tent ready for you. Thank you.
Shelley.
Shelley's the ultimate host.
Yes.
Very good.
I went with an austerity measure today and it's backfiring.
Hey, I support austerity too. I mean, saving paper, trees.
We've killed a lot of trees in the last 2 years with no one actually showing up to the meeting, so.
Thank you for the very kind reminder, Shelley. We do our best. Yes.
This is kind of more discussion topic, and if it's not for this or for me, please let me know. But as more and more data comes out about minimizing licensed sirens use, we want to have a discussion about maybe de-emphasizing response time. I'm putting that in parentheses because I know so much of, like from the governing bodies, it's like you must respond 80% in X number of minutes, but that really kind of goes against the results we're seeing about licensed sirens and how dangerous that is for everyone.
Yeah, I really like that initial question, particularly with the NHTSA push for decreasing licensed sirens use. I think certainly locally we've talked a lot about that. So that would totally be reasonable to request to discuss further at the next meeting. Of could we look at a data point of licensed sirens responses? Thank you. Thank you.
Perfect timing too, because it aligns with the rules work group and the rules package that's being worked on right now.
Right. Thank you.
And I think in the chat there was also a question.
Chris. Chris, thank you for your question. I'm going to punt on this one because I don't know, but I'm going to answer the question to the best of my understanding, and then you guys help me out. So I believe the discussion item that we are going to ask the Bureau's staff to work on is not related to the trauma registry, but rather related to the hospital discharge database. So querying the hospital discharge database to identify those discharged with a hip fracture associated with a ground level fall and describe those cases. I actually don't think for the majority of those cases there will be any AZPers or trauma registry data, simply because those patients are not included. They may be included, but may be difficult. Is that accurate?
We can link to AZPers data.
And the AZPers, we have all the cases, right? If the EMS, because it's an EMS agency, so we will have all. In the trauma registry, if they didn't go to trauma center, yes, we won't have it. So then we have to get it from the hospital discharge database. And then once we get that population, we can certainly link to the trauma registry AZPers if we need some more information on that. But if the patient is not into trauma center, we are not going to. I mean, that linkage is not going to happen.
So the request here, Chris, is not to change how any of the trauma registry data entry specialists are doing anything. It's simply to use the existing data to generate an initial report. So nothing new for trauma registry personnel.
Right, so not to add anything in the annual report, it is kind of a side report to develop to figure these out, which is issue, right?
Yes.
Okay.
Perfect. Thank you for the question and that opportunity to clarify. All right, moving on, call to the public.
May I add an agenda item for next TEPI? Sorry, one more. We'd heard from Carissa on the line about a new trauma registry and having discussions in the coming months about what that would look like. Maria, we also heard you reference we're waiting on that ESO contract, and we believe that'll be executed this week if it hasn't been sent back already.
I just heard we were waiting on the contract from ESO to update to AIS 15, but we don't know a date yet.
So we certainly have some trauma registry topics, I think, to bring forward to the next meeting. I'm sure we'll have some discussions with staff prior to TEPI convening again, but just want to make sure we keep on the radar that as this group comes together, that we do discuss trauma registry needs, and especially if we are going to continue with ESO and or move to a new vendor in the near future. So that'll be an important agenda item.
Thank you. Anyone else? Call to the public items. All right, upcoming events, there's a whole list there. I'm not going to torture you by reading them. You can read just as well as I can. Take a look at those, lots of good meetings virtually and in person. There is a Bureau News and Conferences page. You can see the link there on your agenda. Feel free to check that out. I'm sure that is the most up-to-date area for events, conferences, and other meetings. Next, look at the training programs site on the Bureau. Also, take a look at that if you have any questions about training programs. And with that, next meeting, November 17th, right here, same place, same time. Look forward to seeing you all then. With that, I will adjourn the meeting. Thank you, everybody.
Thank you.
Thank you.
Thank you. Thank you. Bye, Shelley.
Bye.